Hello, good afternoon. Thank you guys so much for joining us. We are here to facilitate our training for lack of diversity, equity, and inclusion in healthcare organizations. And this is specific to AIDS Healthcare Foundation, and speaking to you leaders here today. My name is Gerard Williams.
I'm Medina Dauda.
My name is Odwaya Talabiolawi.
All right, and we're going to dive right in. This is where you will be able to click on our YouTube link to watch the video if you need to refer back to it. Okay, now we're going to start off with a fun little icebreaker. Two truths and a lie. It's a very common, well-known icebreaker that most companies use, or you may have used it at a party before. So the purpose of this, we're going to create three short statements about our career and our experiences there. Two must be complete truths, and then one must be a believable lie. The goal or the purpose is to figure out which one is the lie. So you're highlighting your patient experiences, leadership hurdles, or any unique operational challenges that you've faced throughout your career. So everybody just take a quick moment and write down those three statements. All right, thanks for taking the time to do that. Let's go ahead and get started, and I am going to start us off. So, to preface this, I was a business office manager for an assisted living facility. So, here are my three statements. Once I had to work with the executive director to evict a resident who had multiple sexual harassment claims from other residents. The second one, I've had to step in and coordinate emergency staffing on a weekend when multiple CNAs called out, even though nursing staffing technically wasn't part of my department. And then the third one, our facility received a perfect score on every aspect of a surprise state inspection after I led a 3-day prep. And the surveyor said that they never seen any administrative compliance that flawless before. So which one is the lie? Put it down in the chat. All right, let's see what we got in our chat. So we have number two being the lie. Number two. So everyone thinks the number two is the law, which was I've had to step in and coordinate emergency staffing um, for CNAs. That's actually a truth. So the lie is our facility received a perfect score on every aspect. Number three was the lie. So Medina, you should have went with your first mind.
And she
I
said
should
three
have.
initially.
Number three was the lie. Funny enough, I did have to actually go through the process of evicting a resident who had sexual harassment
Oh
claims.
my goodness.
That's the one that you would expect to be the lie. All right, who's next?
Okay, I'll go next. So here are my three things. And this, to preface this, I've worked as a financial analyst in a transplant department and a financial analyst in School of Public Health. So the first one is I regularly collaborated with clinical teams and physicians to resolve complex financial clearance issues for our transplant patients. The second one is I played a crucial part in submitting a $5 million grant proposal to the state of Texas, along with our chair of epidemiology for the build out of our Epi Lab. And then the number three is I personally approved all clinical treatment plans before they move forward. So, which one do you guys think is a lie?
See if I can put mine in the chat.
Let's see, let's see, let's see. Okay, two,
I said three.
three. Okay, so actually, three is correct.
Woo.
I did not approve any clinical treatments. That is up to the doctors. And two, as unbelievable as it is, I did play a crucial part, and we did get that grant. Actually, they matched it and gave us an extra $5 million. So we are
Oh,
going to
wow.
build out an Epi Lab. So shout out to the state of Texas. We
Nice.
appreciate it. All right, Grace.
Oh, okay. So I currently work in an
It looks like
assisted
we
living.
lost your camera though, Grace.
Ooh, okay. Okay, can you see me now?
Yes.
Yep. Perfect.
All right. So I currently work as a CMA in an assisted living, and part of my work is to draw blood from residents and send to the lab.
Okay.
Number two, I Number two is I administer medication, follow the dosage, and giving the report to the charge nurses. That's number two. So my number three would be I play a vital role in ensuring the patient's safety, prevention of fall at all times. So which one is a lie?
I'm gonna go with number
I'm
one.
gonna say one.
Yeah, number one,
You
I
want to
do
lie?
not have the permission to draw blood.
And that's just because I know what a med aid does. So I'm like, yeah,
Yeah,
no,
you're
I haven't seen a
familiar
med
with
aid take blood before.
that.
All right. Thanks for y'all's participation in that. Okay. Next slide.
All right, so we're gonna jump into the lesson objectives. So by the end of this session, we are hoping the participant will be able to describe how the lack of DEI negatively affects patient care, teamwork, and community trust within the AHF organization. Identify at least 3 leadership practices that support equitable, culturally responsive care. Apply leadership strategies such as cultural humility, bias reduction, and inclusive communication to real world DEI challenges in case recognize their own role in fostering an inclusive and equitable organizational culture. Sorry about that, guys. We can go to the next one. All right, so to kick us off, let's talk about why DEI matters, especially here at AHF. We all know that diversity, equity, and inclusion isn't just some HR buzzword that we just hear. It actually shows up in our day-to-day experience with our
Mhm.
patients and with our staff. And because AHF serves such a large population, especially of African American and Latinos, diverse communities is who face higher rates of HIV. So DEI becomes directly tied to the patient care and not just in the workplace and the culture. So when organizations struggle with DEI, it just doesn't feel uncomfortable. It actually affects the outcome, right? We start to see how things like lower trust is built within the patient and their provider, misunderstanding, frustrations from the healthcare administration, and they just don't feel supported and heard at all. So all of that gets in the way of AHF mission, which is to provide equitable, stigma-free care so DEI is really a mission critical for all of us. And this is actually where leadership plays a huge role. So leaders set the tone by shaping hiring practices, onboarding communication norms, experience performance expectation, and ultimately the organizational culture wants to culturally responsible want to be culturally responsive, where they must start to responsive to the leadership. We can go to the next one. Okay, so key DEI concepts for leaders. So before we talk strategy, we're just gonna set up the scene and show you guys 3 leadership concepts that are essential for cultural competent care. The first one is cultural humility. So this means recognizing that we don't know everything about everyone's identity or their lived experience. Like everybody's different and everybody's story is different. Not everybody who's going to walk in through the door, you're going to know right off the bat. And that's when it comes with don't judge a book by its cover. So leaders who practice cultural humility, they ask more questions, they listen more than they actually speak. They avoid assuming anything about whether it's the patient or the coworker that they're working with. They acknowledge power differences and they commit to lifelong learning. The implicit bias, these are unconscious beliefs that affect how we interpret behavior or make decision. Like they're just innate within us. It's just like, how just you've lived your whole life. You don't realize it, but it's just there. So in healthcare, bias can be unintentionally affect the diagnosis and the assessment, how much time we spent with the patient, where we've seen to where some people will be like, well, the doctor took like 20 minutes to come see me, but when this person walked in, they went straight to them. So that's an implicit bias. The tone of communication, like how you speak to one person because of, no offense, the color of their skin or their walk of life, can depend on how you speak to somebody else. Assumption about compliance and risk, just assuming that because you see someone, may it be a person of color, you automatically think like you give them a diagnosis in your head without even having spoken to them and understanding what they came in there for. So recognizing our own bias doesn't make us bad people, it makes us actually better leader. And the very last one is inclusive communication. This involves making sure that every staff member and patient feels seen, respected, and safe. So this includes using patient preferred names and pronouns, asking them, how would you like to be called, or what pronoun would you like me to use for you? Addressing concerns without judging, like we are here to do a job, so don't judge the patient based on what you've seen, what you've heard, but actually take them at face value for who they are. Ensuring interpreter access. We do live in a world where everybody speaks different languages, especially here in the state of Texas, where we have predominantly we have a very large Hispanic population. So being sure that we have interpreters on hand that we can call, whether it be via Skype, Zoom, or just a phone call. Being sensitive to cultural values. Every culture has different values that they have, and respecting that and actually honoring that shows a different sides to the patient and even to your coworkers. Avoiding medical jargon when clarity matters. So we have to realize that a lot of the patients do not understand our clinical terms. So being able to talk to them in layman terms and letting them know rather than using these big words, because they will leave more confused than before and may not even be able to follow through with treatment just because they didn't understand what was said to them. And then, so effective DEI leadership starts with everyday behavior. It's not like, just little things that you do every day will help you be an effective leader, not major organizational shift. Then we can go to the next one. So these are leadership strategies to strengthen DEI. Lead by listening. So as there's a TED Talk that I watch, and from McChrystal, it emphasizes that listening, like that leadership starts with listening, asking patient about their cultural values, actually getting to know your patient and not just seeing them as another number. Like, sitting down, being present with them, and actually being attentive to what they're saying. Checking in with your staff regularly, like checking in what's going on. Hey, how are you? How are you doing? Is there anything going on? Like asking them about their outside life so that you can also have a better understanding of their cultural values. Creating space for dissenting opinions. So being able to allow your staff, even your patients, to have an opinion on their care or how the organization runs is very effective as well. And then listening builds trust, and trust leads to better care. And then also another thing is addressing bias through reflection and feedback. So leaders require us to look inward within ourselves, and we can practice that by using self-assessment. So checking in with the team every once in a while, having a little survey monkey go out, or even with the patients, like, hey, thank you for coming by, let us know how we did today, like fill this out, and then so on and so forth. Asking for direct feedback. Like as a leader, you can go to your staff, or you can go to this to a patient on their way out. Hey, how was everything? Is there anything you want to talk about? Like, is everything good, or whatever the case may be. And then slowing down decision making in complex cases. Don't just jump to conclusion. Like actually take the time to discern what's going on before you make any big decisions, and not be hasty about anything. And then questioning automatic assumptions. Like always try to think better, bigger, outside the box, and don't just go with just whatever you think is the flow. Another strategies is model equity in team interaction. As leaders, even informal leaders, our behaviors signal what is acceptable. So this includes distributing the work fairly. Don't do favoritism. Everybody gets the same amount of work. Everybody gets to, like, maybe rotating stations. Everybody gets a turn in a different station. Giving equal voices during huddles and meeting, allowing your staff to speak up and let you know what's going on with them. And then calling in but not calling out harmful behavior. Like don't just, scold somebody in front of everyone. We all make mistakes. We're all human. So just don't call out the person, but just more so calling in the behavior. And then maybe having one-off conversation so it's not an embarrassing thing, and then your team doesn't feel like they can't speak to you. Also encouraging diverse perspective during problem solving. And when a team culture is inclusive, I believe me when I say this, patient care improves. And then the next, and I
All
will hand it
right.
off to Gerard.
Thank you. And now we are in our lecture part of our training where we really want to hone in on inclusive leadership and its direct impact on closing the care gap. So our mission, as we all know, here at AIDS Healthcare Foundation, is to provide an equitable HIV prevention, testing, and treatment, regardless of ability to pay. But to truly fulfill the equitable part of that mission, we must address the systemic barriers that undermine our best clinical efforts. The barrier we are focusing on today is the critical intersection of lack of representation and religious stigma. So this isn't about blaming individuals. It's about recognizing that the structural dynamics in Dallas that prevent high-risk patients from walking through our doors and staying in our care. So let's look at the data, which is really going to be our reality check, right? The active U.S. physician workforce is overwhelmingly white. There's 56.2%, while Hispanic and Black physicians combined represent only about 10.8%. Our workforce nationally does not mirror the diversity of the patients that we serve. This mismatch directly affects patient trust and cultural competency, which are non-negotiable in HIV care. So, looking a little closer on the Dallas area, there are 43.7% of new cases of HIV were Hispanic, men who have sex with men, and then 27.7% of those new cases were Black men who have sex with men. They both together account for over 71% of new HIV diagnoses. So you can see the difference in representation. 71% of the new cases, but only 10% of the doctors look like them. This is a massive disproportionate burden on minority communities. While systemic access issues are part of it, for AHF, a major addressable factor is that hidden barrier of religious stigma. So we operate in the Dallas-Fort Worth area where roughly 63% of the population identifies as Christian, with high percentages of evangelical, Catholic, and historically Black Protestants. For patients from those communities, particularly African American and immigrant groups, seeking HIV testing or care could trigger a fear of judgment or exclusion from their faith community. Um, this could lead to delayed diagnosis, reduced treatment adherence, weaker linkage to care. And we know that as leaders, we need to understand that this is a strategic risk. And without religiously responsive practices, we see reduced testing rates and poor outcomes, which directly undercuts AHF's ability to achieve its public health goals. If a patient feels their care team cannot or will not understand the deepest source of their hesitation, their spiritual or community identity, we lose them, regardless of the quality of our clinical services. So it's very important that we, stick out from the rest. There aren't a lot of medical facilities um, who inform patients of their doctor's faith beliefs. But I think it's important for those also not to just have representation of what we look like and Black people having representation for being Black, but we also need representation for their um, faith-based as well. Grace, you go ahead and take it away.
I think you're muted, Grace.
Oh, I'm sorry about that.
That's great.
Okay. All right, thank you. So we're going to be talking about the leadership and management strategies. I'm going to be talking about two micro level leadership strategy and a macro. So leadership role is to influence the organization culture that shape these patient experiences. We move now from data to concrete actions. starting at the micro level, what you can implement in your clinic and teams immediately. So what is that micro strategy? Number one is I'm going to call this staff cultural and religious training. So what is the action in this training? The leader is to implement a regular team training that will focus on diverse faith perspective, which will include the Christian, Muslim, Jewish, African traditional. This isn't just sensitive training, it is a cultural humility. It is the recognition that we never be expert in another's culture, but we must be willing to learn and defer to the patient's content. So, what is the role of the leader here? You must normalize and lead non-judgmental conversation within your teams about how faith influences health behavior. The number two strategy is confidential access alternative. So, what are you supposed to do here? Like the strategy. So here, the management is supposed to offer private appointment time, especially for those people who, might not have that confidence to, come out for their testing. So they can encourage a mobile testing, like in a discrete environment that is not open to everybody. Maybe it's probably not on, that is off-site. So that's what they can do, like make it a confidential appointment. Then the third one is going to be the third strategy is going to be to establish a religious diversity advisory board. So this board, we need to create an advisory council that composed of diverse faith leaders from the Dallas area. So we are taking the case study, like the organization we are dealing with in the Dallas environment. So this leadership board can comprise the evangelical, the Muslim, the Black church leaders. They are to provide policy recommendation, to reach outreach materials for cultural competency, and help to navigate the delicate community issue, like all those concerns with those culture. So these board members will come together and they're going to come together to make recommendation on how to deal with those community issues. So, and lastly, what is the call to action? The call to action here is that the connection is clear. Lack of DEI creates stigma. Stigma delays diagnosis, and delayed diagnosis contradict our mission of equitable care. Our overreaching call to action for every leader in this room is to, what is the call? Integrate racial, ethnic, and religious diversity into every stage of HIV service delivery. Train your team to recognize how representation of faith influence testing and healthcare service decision to fulfill our mission. All right, thank you.
Great. All right, those slides went along with what we just discussed. I think that's yours as well, Grace.
Okay. So what is the case study that we're going to be dealing with? So I'll read. During a community outreach in South Dallas, local faith leaders voiced concerns that HIV testing contradicts their community morals belief. As a result, participation in testing events drops by 40%. Staff are uncertain how to respond respectfully while still promoting public health goals. So what are the questions that we have to consider in this case study? Number one, so how should the organization leaders approach this issue while still maintaining respect for religious values? The second question is, what role could faith-based community partnership play in reducing stigma? The third question is, which of the proposed micro or the macro level strategy that we have discussed could be most effective here? And lastly, how can leaders evaluate success without alienating the community?
All right. So what we're going to do here is we're going to break out into breakout groups, and you guys have about 20 to 25 minutes to discuss these questions. And then once we come back together, we will pick out some groups to discuss, and we'll get some great discussion going on that. All right. So go ahead and go to your breakout groups, and we will see you in about 20 to 25 minutes. All right. All right, so with this slide, this is our additional resources. Thank you guys for coming back and discussing everything from your breakout groups. That was some really great discussion. And I feel like we have a really solid path to move forward here at AIDS Healthcare Foundation with creating more diversity and inclusion. This, again, is a slide where we have additional resources that you can look into. And now we will take questions. Does anyone have any questions for us? Nope. That's a good sign. That means that you guys really learned something and we are ready to see that what you learned in action.
And then we will have a post-education evaluation question where you will respond and kind of respond about the training and what you've learned and any plans, any actions that you plan to take, anything that you want to let us know how we could improve this session in an open comment. So if we go to the next slide. So we will pass out this evaluation question, and we also have a link to a Google form so you can get that completed as well. And here are our references that we used. And we do want to thank you all for coming and participating in our training today. Below here is our contact information, so please feel free to reach out to us at any moment if you have any additional questions. And we hope to have made an impact and you understanding the lack of DEI and moving forward. So thank y'all so much, and y'all have a wonderful evening.
Thank you.
Thank you.